I think you have to unmute, Ghanshyam. You have to unmute yourself. Unmute. I think you are muted. You have to unmute, Ghanshyam.
Very good morning,
Yeah.
friends, colleagues. At the outset, thanks to the team NUCD for inviting me. So I'm going to discuss diabetic neuropathy and diabetic foot syndrome. Diabetic foot syndrome is defined by WHO as an ulceration of the feet above the malleoli associated with neuropathy and different grades of ischemia and infection. As you all are aware, cost of diabetic foot ulcer is greater than that of the 5 most costly forms of cancer. Every 20 seconds, someone is amputated. Lifetime risk of people with diabetes to develop a foot ulcer is 34%. More than 50% diabetic foot ulcers become infected. As we all know, medium time to healing a DFU without surgery is approximately 12 weeks, and it is associated with a high risk of limb loss through the amputations. 5-year survival following presentation with a new DFU is of the order of only 50 to 60% and worse than that of many common cancers. They one of the very important paper which has been published by Professor Bolton and David Armstrong in 2017 in New England Journal of Medicine. And what they have shown that the incidence of diabetic foot ulcers, lifetime incidence, is around 34%, not 15 or 25%. And simultaneously, if a person's ulcer is healed, the recurrence rate within 1 year is 40%, and it increases by 60% after 3 years. So what they have suggested, instead of telling our patients that your ulcer is healed, that we should use the term, your ulcer is in remission. Who is at the risk of foot ulceration? Patients who are in neuropathy, peripheral vascular disease, posterior foot ulceration, microvascular complications, poor glycemic control, smoking, foot deformity, and amputation. These are the patients who will be at the high risk. Then how to define neuropathy? I think this is the simplest definition. You all have known to this definition. Presence of symptoms and or signs of peripheral nerve dysfunction in people with diabetes after other causes has been excluded. So diabetic neuropathy agonizes when it's painful and damages when it's painless. Among diabetes complications, damage to the peripheral and autonomic nervous system is the most prevalent. And effect of DPN on patient morbidity and quality of life are substantial. It predisposes to falls and superficial injuries, which can lead and amputations. Painless diabetes not aware of minor foot injuries that can become major problems. Cause of alopecia is believed to be related to the blockage of small arteries that supply affected nerves. And patient is not any that is there. Then patient is not feeling a problem with it. There is a motor nerve damage on motor neuropathy. There is a bursting of the small muscles of feet, and there is a clawing of feet you can see. And the autonomic nerve damage, you can see dryness of feet, loss of hairs, and cracks, which are suggestive of autonomic nerve damage. Localized callus, it is a precursor ulcer. We all know that's there. Then this is the patient which came to us, long-standing diabetes and having a non-healing ulcer since more than 1 year, and you see what is there, that the staplers were inside and patient was not aware of it, and patient was not having on account of loss of protective sensation. Then the monofilament sites for testing, you see these are the 3 sites, now the 5. Grade 2, first empty head and 5th empty head. Out of these 3, if 2 or more than 2 places patient is unable to feel, it means patient is having loss of protective sensation or patient is having sensory neuropathy. So the International Working Group on Diabetic 2019 guidelines. Then this is how you categorize the high risk fit. If patient who has no LOPS, no PAD, no deformity, in the risk category 0, and patient should be examined by a journalist or a specialist every year. If patient has LOPS plus minus deformities every 3 to 6 months, grade 2 PAD, peripheral arterial disease plus minus LOPS, loss of protective sensation, every 2 to 3 months. And if a patient is having history of ulceration or amputation or sharp foot, every 1 to or whenever patient comes to you. So stepwise approach for primary care. All individuals should be assessed for diabetic peripheral neuropathy, starting at diagnosis of type 2 diabetes and 5 years after the diagnosis of type 1. And after that, at least once in a year. This is the how you diagnose the painful diabetic neuropathy. Take a targeted history, assess for diabetic peripheral neuropathy symptoms, test for clinical signs, develop a differential diagnosis, and perform a confirmatory testing if needed. So history, you have to go for if poor glycemic control, long duration of diabetes, older age, tall stature, as the neuropathy is length dependent, hypertension, obesity, and metabolic syndrome. These are the patients who are at high risk of diabetic neuropathy. Then about the large fiber or myelinated fiber neuropathy and the small nerve fiber or unmyelinated C fibers neuropathy. Symptoms: numbness, tingling, poor balance. And how you examine? You do a ankle reflex, vibration perception threshold, 10 gram monofilament, or you can go for proprioception. But about the small nerve fibers, you can have thermal or cold or hot discrimination, or pin prick sensation, which is absent or reduced, or patient may have pain, burning, electric shocks, stabbing, hyperalgesia, or anhedonia. Small fiber neuropathy: burning, lancinating, tingling, shooting, electric shock-like sensation, occurring in varying combinations and typically worse at night. Pain may be accompanied by dysesthesia, such as exaggerated response to painful stimuli. Then pain may be directly or indirectly interfere with daily activities or lead to loss of balance, disability, psychosocial impairment, sleep disturbances, and reduced health-related quality of life. Thus, there should be a strong suspicion of DPN in individuals presenting with any of these complications. About the large fiber neuropathy: numbness, tingling without pain, loss of productive sensation, in more advanced stages, more balanced weakness and unsteadiness that may lead to fall. Some individuals may also present with completely insensate numb feet. Asymptomatic diabetic neuropathy. Half of the people with diabetic peripheral neuropathy may be either asymptomatic or reluctant to report some symptoms. So, to summarize, periodic, flexible assessment for diabetic peripheral neuropathy risk factors and symptoms and their trajectories of time should be part of standard care for all people with diabetes. What are the tests? One is for the small fiber damage, pinprick sensation using sharp objects such as safety pin, temperature threshold sensation, which will mostly performed with a cold metal such as tuning fork, or for the large fiber neuropathy, you can use a 128 hertz tuning fork, or you can touch light touch pressure with a 10 gram monofilament, or you can use a biothiometer or bilateral ankle reflex. So how to manage DPN? Management remains suboptimal. In type 1 diabetes, glucose control slows DPN progression. In type 2 diabetes, glucose control only marginally affects DPN progression, especially when patients have metabolic syndrome. Therefore, managing DPN in people with type 2 diabetes currently revolves around weight loss and exercise to mitigate the metabolic syndrome. About the peripheral neuropathy, that is painful. 30% of all individuals with DPN will experience painful symptoms that will require pharmacological and other treatments. Role of glycemic control, it's an important point. Early studies suggested that stable glycemic control with few excursions into hyperglycemia or hypoglycemia was associated with reduced pain scores as assessed on a VAS. Later, with the advent of continuous glucose monitoring, a small study confirmed people with painful DPN have greater fluctuations in glucose and poorer overall glycemic control than MASH subject with painless neuropathy. Acute painful diabetic neuropathy, as in the past we used to use it as an insulin neuritis by recent review by Gibson have suggested we should call it the treatment-induced neuropathy of diabetes, as insulin is not the only cause to cause the neuropathic pain or insulin neuritis. Chronic diabetic neuropathy, common among all ages in both type 1 or type 2. And what is therapeutic approach? There are no pathogenetically oriented pharmacological treatment approved by US FDA. So there are 3 FDA approved therapies for painful DPN: pregabalin, duloxetine, and tapentadol. So how will approach? First, identify person with painful neuropathy. Other causes of the neuropathy should be excluded. Non-pharmacological therapies. Then pharmacological therapies, which is anticonvulsant, pregabalin and gabapentin, SNSRIs, duloxetine, tricyclic antidepressant. If not, then it's a combination therapy. Multiple drug combination therapy isn't listed in this figure. Means you can use a combination of pregabalin plus duloxetine, or you can use a nutraceutical just like vitamin B12 and others, and even local treatment. The capsicum 8% patch is also there. So pharmacotherapy should be individualized, depends on comorbidities, cost, potential drug-drug interaction, potential for adverse effects, and all the factors to be taken together. Different drugs for the treatment of painful diabetic neuropathy. There was a meta-analysis which have shown pregabalin and duloxetine shows good therapeutic effect on painful DPN, but adverse effects were also significant, so always remember it. Topical therapy, now 8% long-acting capsicum patch has been developed, is now approved by FDA for painful diabetic neuropathy. Duration of treatment, this is very important. It is recommended that after 6 months of symptom relief, a slow and gradual reduction of drug treatment should be attempted. If symptoms reappear during this gradual reduction, a lower dose may be required for the next few months, when further review and attempted reduction should take place. This is a typical presentation of the diabetic foot syndrome in clinics. We also neuropathic foot, infected foot, the foot with the maggots. And neuropathic foot, we all know a lot of callus around the ulcer. It is on the plantar surface, and the wet infected gangrene, plantar callus, and there is a loss of protective sensation. While neuroischemic foot, this is called not pink, it's black, pulseless, or it's not painful, it's very painful, marginated ulcers. So what are the modern day management of DFU? We all know it is the debridement and infection control, then the offloading and vascular assessment. And nowadays, in addition to this simple multidisciplinary diabetic foot care, the simple principles, multidisciplinary diabetic foot care is now becoming a mainstay of the therapy. So I'm just going to have a 2-3 cases discussion regarding this particular thing. One is the neuropathic foot, bilateral cratoid and second empty head ulcers, multiple ulcers, history of barefoot walking, and since last 5 months, this monofilament test was severely impaired or not able to feel. ABI was normal, X-ray doesn't show any osteomyelitis, and you see patient debridement was done at the clinic, and offloading was provided by the most modified posterior slab. One is this, and second, then it has been given the offloading by the foam dressing or SK offloading based on principles of Samadhan system. Then outcome after 15 weeks, you see these ulcers which were there, it has been healed after 15 weeks. So only problem in these ulcers, why they were not healing, was the lack of offloading. These are the offloading ways, how you will check it. So gold standard is the total contact cast, then posterior slab, and all these bed rest is not practically possible. The different ways of offloading. There's a felt form dressing, total contact cast, there's a modified footwear, posterior slab, and the air cast. This is the infected diabetic foot, extensive gangrene of lower 1/3 of the foot. Hemoglobin was less than 7, creatinine was high, and patient was in very sepsis, and patient required below knee amputation. Discuss with a family member and life-threatening situation, and you see, to save the life, the major amputation, below knee amputation has been done. So below knee amputation is a life-challenging event. It is a last resort when all options of saving the limb have failed. Sometimes BKs are performed in order to save the life of the patient. Advances in surgical procedure and improved and advanced processes have enabled patient to return to almost near normal life post-amputation. This is an ischemic case presented with severe pain in the right foot, 2 weeks, a smoker, pedal pulses were not palpable, A1C poorly controlled, creatinine 1.54, right lower limb artery shows occlusion of SFA and popliteal artery. Angioplasty has been done, and you see, after angioplasty, after 1 week, this amputation of the great toe has been done and it has been healed, and you can see this is the result. So it's a multidisciplinary approach. So that's why nowadays multidisciplinary approach is mandatory. You require diabetologist, endocrinologist, or physician who is the captain of the team, then surgeon, plastic surgeon, vascular surgeons, podiatrist, orthopedic surgeon, all these are required, and the orthotist or podiatrist. So dear friends, to conclude, diabetic peripheral neuropathy is one of the commonest complications of diabetes. Peripheral neuropathy agonizes when painful and damages when painless. Diabetic neuropathy can be nightmare for both, for the patient suffering from it and for the clinicians trying to manage it. Fit have to bear the major brunt of damage done by painless peripheral neuropathy. Protective and preventive measures are the most important aspect of fighting painless neuropathy. So dear friends, pay attention to the basic tenets of wound care. Nothing supplants the role of good basic wound care. Offloading, debridement, infection control, management of ischemia if necessary. Keep Indian scenario in mind, availability and affordability. Thank you very much for giving patience hearing. Thank you.